So here are my disclosures. Happy Easter. So I'm going to start with politics. And you've already heard that there is an initiative in Germany to rename lipedema. So you heard it from the Lipedema Foundation and also from Dr. Schwartz. So the German Society of Phlebology, headed by Erika Mendoza, and the International Union of Phlebology, headed by Professor Vador Lurie, are spearheading this effort. And there's a questionnaire, and you're supposed to go and put a new name in. I think it's a little bit too early. I'm not saying it should never be renamed, but I think it's early. If you haven't seen the initiative, you can watch it on YouTube. And they're actually presenting it in October of this year. So it's not a matter of if, it's a matter of when. So by October, we'll know what they picked. And you can give your opinion on what you think the new name should be at the Total Lipedema Care table. I know this is a really busy slide, but this is nice. It's the National Institute for Health and Care Excellence, and it's in the UK. And they evaluated whether the National Health Service should pay for liposuction for lipedema. And what they decided was no at this time. But that's not a big no. What they said was, hey, there's not enough efficacy data, there's not enough safety data, so more research needs to be done in this area. And they even took it a step further. They said, when you do research, do this. And that's seen in 1.2. So be careful with your patient selection. Describe your patients really clearly, because there's so many different varieties of lipedema, let's say. Everyone's their own unique person, so describe them very well. Talk about your procedure. What procedure are you doing? What cannulas did you use? How much did you remove? What kind of anesthesia did you use, etc.? What are the long-term outcomes? And is quality of life improved in these ladies with lipedema? Because that's the big deal. If your quality of life isn't improved, we probably shouldn't be doing this. And it also, that patients should be selected by a multidisciplinary team. So it should be maybe a physician and a therapist, or maybe multiple therapists and multiple physicians. And that the procedure should be done in a specialist center by people who are familiar with lipedema, and not somebody that says, well, I do liposuction, so I can do lipedema. Now, if you haven't heard, there is a new association called the International Lipedema Association. This was started by Tobias Birch. It was founded out of the Foldy Clinic in Germany. It was founded in 2021 by 60 healthcare professionals in 22 countries. And it sounds great, right? An international society to create the best possible treatment for lipedema. Be inclusive. We want diversiveness, long-standing experience, etc. It all sounds really good. And you can actually go online and you can look at this society yourself. But I will tell you, they don't include patients. And they don't include patient groups. It's only professionals. And they don't feel that they need the patients. Whereas I feel like you guys are the patients and you're allowing us in, right? Because we learn from you. How else are we going to learn? You don't learn about lipedema on your own as a professional. And what this group also says, and they have a brochure that's out online and you can download the brochure, there is no edema in lipedema. There's no fluid in the tissue. Lipedema does not cause lymphedema, and it does not worsen over time unless you have obesity. Only if you have obesity does your lipedema worsen over time. Okay, so here are your therapies. In their association, there is no MLD for you. You wear compression garments, not because you swell, but only for the pain. There's no pumps, no compression pumps for you because you don't have edema in your tissue. And no patients or patient organizations. So that pissed me off. And I mean, we've got lipedemons, right? Got to get, we got to take care of our lipedemons, and how are you going to do that without all this stuff? So I've been working with the Lipedema UK, Lio Italia, and Limpa from Portugal. And we are going to start another group. And they have kind of a name, but it's not been incorporated. We just got funding for it. And what we want to do is to be open to all science. We don't think it's early enough to put a kibosh and say there is no this or there is no that. We just don't have good scientific backing. So what I say is there are two sides to the coin. Whether there is edema and lipedema or there's not edema and lipedema, we don't know yet. If you only look at one side of the coin, it's like saying that the world is flat. So watch for that in this next year. I'm sure that will be incorporated in this next year, and we're hoping to get as many international folks to join, and we want patients, and we want patient groups. So in 2021, you all know that we came out with the standard of care for lipedema. Ooh, that's gonna make me cry. And there's so many people in this room who contributed to this, and this was a true consensus, unlike other consensus documents that are out there. Everyone participated. It was one of the best working groups I have ever been in my life. It just flowed. It was fabulous. There was good feelings, and we all really care about people who are living with lipedema. And the reason we did it is because lipedema remains a misunderstood disease, right? It's misdiagnosed as obesity, or it's misdiagnosed as lymphedema or other things. And other countries had standards of care, but we did not. So it was first described here at the Mayo Clinic in 1940, but we didn't have a standard of care. So done, check, next. So we had 85 statements in the standard of care. And I just am gonna show a few here that I think are important. Number one, that lipedema should be regarded as a loose connective tissue disease versus a disease of just adipocytes. So we really want to look at lipedema as a problem with connective tissue and not just fat. And we believe that there is edema in lipedema tissue. We may not be right, but we think that women with lipedema do benefit from complete decongestive therapy. They do benefit from compression garments in terms of swelling, and they do benefit from pumps, as well as other manual therapies. And also that the abdomen can be affected in women with lipedema, and even maybe other areas of the body. So it's not just restricted to the arms and legs, and this has been called rubbish by the other society. And it's not just me that thinks there's edema in lipedema tissue. So this is a really good paper that came out of one of our buddies, Steve Dean, who couldn't be here this time, and he was also on the standard of care committee, and his colleagues, and they looked at edema that was caused either unilaterally or bilaterally. So it's two sides there. And for the unilateral, we've got primary venous diseases. And you heard Jerry Bartholomew talk today. There's a lot of vascular disease in women who have lipedema. So, and venous disease is one of them, and that could be contributing to the pathology of lipedema, more so in some women than others. But also, lipedema and obesity contribute to the development of edema. So there's so many reasons why there should be edema in lipedema tissue. So again, we shouldn't be closing the door. So what is edema? Edema is defined as the swelling of soft tissues due to increased interstitial fluid. So there you've got my little cartoon there. So you can get increased fluid in the interstitial space, which means between your cells, in a number of different ways. One, you can increase pressure in the capillaries, and the capillaries feed fluid and food to the tissue. You can have venous disease, which will increase pressure in the post-capillary venule, the little segment after the capillary, or in the capillary itself. You could have hypertension, congestive heart failure, so many reasons why you would increase pressure in the small vessels. If you have decreased proteins in the blood, then fluid can't be held in the blood by those proteins, and it just goes into the tissue. If you have damage to the walls of the vessels, particularly the glycocalyx, more fluid can enter the tissue. Or if you obstruct the lymphatics, prevent them from working efficiently, maybe they don't pump as well, then fluid can build up in that interstitial space. And usually when we talk about fluid in the body, we talk about how does it get in there and how does it get out, but we don't talk about the interstitial space. We pretty much so ignore it, but we did not ignore it in the standard of care. So what's really interesting is when we think about edema, this is what I was taught when I was in medical school, in the 15 minutes that I got my education on the lymphatic system, was that edema is high protein. So all these proteins come out of the capillaries and they sit there in our tissue. But actually, quite some time ago, it was shown that women with post-mastectomy edema have low protein in the fluid. Protein is low. The bigger the affected arm gets, the lower the protein. So it's not protein getting stuck in there. So what is it? Is it just free-flowing fluid? It can't be, because we don't see it as well. So what is going on? So the same group found that as you increase fluid in that interstitial space, what increases is this molecule called hyaluronin, or hyaluronic acid. And it is a glycosaminoglycan. It is a sugary molecule. It's just pure sugar. And that sugar binds up water, and it binds up sodium. So the more of this hyaluronic acid you have, the more fluid you can bind up, forming this gooey gel, and the more sodium that builds up, and maybe that's why Shelley Krasinski is seeing more sodium in the tissue of women with lipedema. Maybe it has to do with that interstitial space. So what that hyaluronic acid does is the minute you start swelling, it increases and binds it up because it protects your body. Your cells don't want to sit in fluid, right? They want to just do their thing without drowning. If fluid sits there, they drown. So that hyaluronic acid binds up the fluid and creates a pressure that prevents fluid from entering the tissue and promotes fluid from leaving the tissue. So it's a beautiful system. And on the top there, you can see the hyaluronic acid, and it's just repeating sugar molecules. And that hyaluronic acid can bind to proteins, which themselves are bound to other glycosaminoglycans, which are also sugar molecules. And it forms this huge complex. And when you increase the amount of adipose tissue you have, by whatever means, non-lipedema adipose tissue, lipedema adipose tissue, you increase the amount of proteoglycans in your tissue. So you bind up more fluid. So if you have a big clunky gel sitting in your interstitial space, do you think you're getting good flow through the tissue? No, things are getting congested. So when your therapist says, oh, I feel you're very congested, you could think, maybe I have a lot of hyaluronic acid gel in my interstitial space. I knew you were all thinking of it just like that. And this is what an actual proteoglycan complex looks like. Doesn't it look like a jellyfish? So you can think of, I can already see hashtag jellyfish. I got jellyfish inside my tissue, right? It's a new thing, but it is a gooey substance in your bodies. And that's an electron. I just geeked out when I saw that. So having these glycosaminoglycans, these sugar molecules, so maybe low-carb diet, maybe that's a good idea. Having these sugar molecules inside of your interstitial space is probably how our body adapts to fluid fluxes. So initially, it helps us, right? It binds up water and protects our cells so they don't drown. But as time goes on, you keep binding and binding and binding, binding and binding, and pretty much so you have a glue inside your interstitial space and things aren't flowing well, right? And that's when those lymphatic vessels likely get damaged. And that's what these authors said for lymphedema, and I think the same is true for lipedema. It's in the spectrum. Lipedema is in the spectrum of lymphedema. So what is the definition of edema? It's swelling of soft tissues due to increased interstitial fluid. And now you know that that interstitial fluid can either be bound to glycosaminoglycans or it can be free. Okay, let's get into research. So I just want to thank the Lipedema Foundation because they continue to promote research in this area, and they're really a driver for research being done on lipedema. So let's say thank you. So when we were going to be here last time, we didn't really have a ton of data showing that lipedema tissue is different from non-lipedema tissue, but now we do. We have multiple studies showing that the actual histology, when you do a biopsy and look at it under the microscope, it's different looking. There's different gene expression compared to non-lipedema adipose tissue. There are different lipid molecules in lipedema tissue compared to non-lipedema tissue. And there are different hormones that are being secreted in different patterns than non-lipedema tissue. And thank you, Sarah Al-Gadban, but there are different adipose tissue-derived stem cells in lipedema tissue compared to non-lipedema tissue. So there you go. I mean, if they say, well, you're just fat, you can say, oh no, there's a lot of data to support that my tissue is much different than somebody who developed obesity in a different way. So thank you. Lymphedema. So looking at genetics of lipedema, there are over 28 genes associated with lymphedema. That's a lot, but it only explains about 30% of the cases. So kind of just being real, if you find a gene for lipedema, it's great, but it may not, and I think Guy can explain this, it may not explain all of lipedema. There may be many genes that are associated with lipedema, and as we find more and more, it'll explain more and more of the cases. And it may be very complex. It may require multiple genes, and it may require an interaction with the environment as well. So when we think about the genetics of lipedema, what do we think about? So lipedema arises in many cases as an autosomal dominant genetic change in a gene or a set of genes. And this means that if you have just one gene for lipedema, you have a 50% chance of passing it down to your son or your daughter. And there's a sex preference. This mainly happens in females. So that means that fathers who don't look like they have lipedema, they're skinny, they're fit, they don't have any excess fat on their body, they can pass it to their daughter. So here are some genes of interest in lipedema. And I mentioned 3 of these this morning. So one is BUB1, which is a regulator of proteins involved in cell proliferation, and that makes sense. We've got a lot of increased lipedema adipose tissue, if you mutate something that controls the growth of adipose tissue, now it's out of control. And then the fusion partner gene, which is associated with lipomas, and many women with lipedema have lipomas. And then BBS4, which causes a gender-specific increase in adipose tissue. I mean, that fits it right there. I want it to be BBS4, but it may not be. And then there's AKR1C1, and this codes for aldoketoreductase. And what aldoketoreductase does is it metabolizes progesterone, so it inactivates it so it doesn't work. So if you have a mutation in this enzyme, then your progesterone levels rise to an abnormal level, and high doses of progesterone make fat grow. So that may also explain some cases of lipedema. And there's also known genes associated with syndromes where they develop what looks like lipedema tissue. So now there's a whole slug of genes, and the last time we were together, we couldn't even say one. So that's truly amazing. So this paper just came out, Sandro Michelini from Italy, and he's actually sponsoring the new organization. And they looked at a whole bunch of women from Italy and the US and looked for variants in the genes. And they only found variants in 17 of the women. So, what does that mean? There's a ton of women and only 17 showed variants. So we're looking for something different that we don't quite understand. But with that said, we have that first set of genes, and now we have a second set of genes, and maybe we could put this together in a panel and test a lot of women and see if those women have these variants in it, and if one kind of stands out more than the other. So I bet you pretty soon there'll be the lipedema gene panel. Have you done your lipedema gene panel? I did my lipedema. Okay, we know from Dr. Afrin's talk that there are a lot of linked comorbidities to lipedema, and one of them is joint hypermobility. And I think that when you have really bad mast cell disease, and Dr. Afrin can correct me if I'm wrong, but you can actually get joint hypermobility if your mast cell disease, and there he's shaking his head, good, if your mast cell disease is active. So it may be that back in the day when I was identifying joint hypermobility, I was actually identifying mast cell disease. So With that said, I've seen a lot of ladies with lipedema who do have what looks like hypermobile Ehlers-Danlos syndrome. I've sent them to geneticists who have confirmed it, so I do think that there is a link to hypermobile joints. And what's interesting is that they have linked fibromyalgia to hypermobile joints. And it's very common among young females to have fibromyalgia and hypermobile joints. And I'm sure some of you remember, like when you were going through puberty and you were younger and you're like, your legs hurt and your arms hurt and your belly hurt and your back hurt, and you're like, why am I in so much pain? Why do I have these hypermobile joints? And now I have lipedema at the same time. And there's actually a 20% prevalence of hypermobile joint syndrome among young adults, 20%. And I think mast cell, we're up to 17%. So these things are definitely overlapping. And mental health is frequently associated with fibromyalgia and hypermobile joint syndrome. And it's not saying that if you have these, that you have mental health issue. It's just saying sometimes in the families, you can find these issues. And I've heard it time and time again. A woman will come in, she's got lipedema, EDS, POTS, mast cell, and she's got a child who has autism. And she's got another child with ADHD. So there's a linkage between them, and we need to continue to remember that not only are our bodies affected, but our brains are at risk as well. So this is a study that just came out in 2021? Yeah, 2021, and they looked at pain between women who had fibromyalgia and women who had lipedema. And what they found was that women with lipedema, as you probably know, had a lot of tenderness within their connective tissue, whereas women with fibromyalgia had widespread pain, joints, muscles, connective tissue. And comorbidities were far higher in fibromyalgia. There also was a poorer level of physical, mental health, and quality of life in the patients who have fibromyalgia. And fibromyalgia patients had essentially normal exams, but their symptom levels were much, much higher than women with lipedema. And that's been known for a long time. So what they think in these fibromyalgia patients is that they're centralizing their pain into their brain. So their brain is perpetuating their pain, and it's no longer visible in their body. And then their HPA axis is getting activated, so their hypothalamic pituitary adrenal axis. And Dr. Afrin mentioned this, when your corticotropin releasing hormone goes up because of stress, it directly activates your mast cells. So in fibromyalgia, it's probably bringing in mast cell activation disease at the same time, and there's no data on that in lipedema. But could it be that the same thing is going on in lipedema? So I hope we see some more research into the hypothalamic pituitary axis and the sympathetic nervous system in lipedema. And now they're considering fibromyalgia to be an immune-mediated disease. So they took immunoglobulin G autoantibodies from mice that had fibromyalgia-type symptoms. Whether they had true human fibromyalgia, don't know, but having a mouse model is helpful. So they took those IgG autoantibodies and they put them into a mouse that didn't have any symptoms, and what do you know? They developed fibromyalgia-like symptoms. So the immune system may be very important in fibromyalgia, and it may be very important in lipedema, and you can actually get tested to see if you have an immunodeficiency consistent with fibromyalgia, and I have a link there. And basically your physician just needs to say, yeah, I'm gonna order this test in my patient, and then you go online, you fill something out, and boom, you can get tested. And they'll actually tell you where to go get tested. And most insurances cover it. So I don't mean to say that women with fibromyalgia do not have unbearable pain. This is a study that came out just this year, and it says women with lipedema live with unbearable pain. For this to be made visible, it needs to be given a voice, not only by the person in pain, but by those who might be able to relieve it. And I am just delighted that we have 60 professionals signed up for this meeting, and and we're your partner. We're your partner to help you relieve your pain. And making pain visible is a joint project, right? It's us and you together. It requires your body and your voice to be believed rather than doubted or bypassed. And I'm summarizing here, but doubting the reality of a patient's pain amplifies their suffering. And I'm sure some of you have been through that. By disbelieving women with lipedema, the already private experience is made even less visible to others. And women tend to be less visible overall, so this is like a double whammy. So having one's pain and suffering recognized and confirmed is vital, since this creates a power to make it bearable. And I want all women to raise their testosterone levels. Come on, put your hands on your back, raise it, because you are powerful. This is an interesting study that came out by Herpertz, and I think Guy Eakin already mentioned it, but this author believes that about 100,000 women in Germany have lipedema. That's a prevalence of 0.2%. And we're saying, 5 to 10% of women have lipedema. So is lipedema a rare disease or not? Let's look at both sides of the coin. Until we have more scientific data, we really don't know. But another thing that came out that was really interesting in this paper was that Herpertz found that there was fat tissue on the hands in 23% of women with lipedema, and on the feet in 5%. And way back in 2015, my colleagues and I published that we found fat on the hand in 22% and on the feet in 6%. That's almost identical, right? And that is not lymphedema. It's maybe not exactly lipedema. It might be just the hypermobility of the tissue letting the fat grow. Or there might be something else going on, and I think that we should study these ladies. Jumping into some imaging, so this is also a recent paper, came out last year, looking at ICG in indocyanine green in women with lipedema, and they measured how far the dye went in 10 minutes and 25 minutes. They did some massage, but really the take-home message here was that the longer you have lipedema, the slower the dye moved. So we need to intervene early before you get to that point. And they didn't see any abnormalities of the lymphatic vessels. And we're going to hear a little bit later from Dr. Chen that that's probably not true. And this is a paper that's like hot off the press. Like last week it got accepted, and this is from John Rasmussen, Eva Sevick, Carolyn Fife. And this was actually supported by the Lipedema Foundation. And they showed that the lymphatics are pumping a lot faster than controls. Like they're pumping and pumping and pumping and pumping and pumping and pumping and pumping. So why are they pumping? Are they trying to move out some excess fluid that's in that interstitial space, perhaps? Are they trying to get that gel that's all clogged up in that interstitial space out? So I'd love to hear your opinion on it. We don't know the answer, but clearly there's something different in women with stage 1 and 2 lipedema compared to controls. And same for stage 3. We were just looking early. We wanted to say what's happening early so we can understand lipedema before other things intervene like obesity. And the other thing they found is that the vessels were dilated and they had intravascular pooling of fluid. So there's something's not right. They're getting either damaged over time or there's something wrong early on, and we just don't know. Look at two sides of the coin. Let's wait and see. And this is an interesting paper. It came out in 2019, and we actually met in 2019. But this is a picture of female fat. And you can see the top layer, you can see the bottom layer, you can see some muscle, you can see some skin, and you can see some big fibrous pieces that are kind of holding things together. Look at how thin the tissue looks like on the upper part. Super thin, right? It doesn't look very strong, does it? Now, this woman is classified as obesity because her BMI is greater than 30. So it is compared to a man's fat. And granted, he's not obese, okay? So they're very different, but at the same time, look at how strong that fat looks like in the man. Super strong, right? Like nothing's gonna make that fat sag, right? Is that why we're so saggy? And I'm serious. If you build up a bunch of gel, heavy gel full of fluid in your interstitial space, and a lot of fibrotic tissue, doesn't that make the tissue heavy? And if it's gonna sag, who's it gonna sag in? The woman or the man? The woman, right? Maybe the structure of the fat is the reason why men are protected against developing lipedema. Could be. Put that bee in your bonnet. So men's fat's stronger, and I think it actually may contribute to the development of the folds on the body of a woman. So our fat's different than a man's, and we need to take that into account. So treatments. Yep, we have some now. So I'm just gonna start off just easy peasy. So what burns fat? I get that question all the time. How do I burn this off? So calcium, so eat calcium-rich foods. Vitamin D, keep your vitamin D level within the normal range. It's an anti-inflammatory, and it helps you burn fat, and that's pretty easy, and your PCP is more than willing to help you do that. Caffeine, so yes, I see some caffeine. You can drink that. And catecholamines, as I talked about this morning, rise, especially when you fast. So there is a study that just came out saying intermittent fasting isn't any better than caloric restriction. Well, that's good. They're equal, right? But it does increase your catecholamines and may be beneficial for women with lipedema. Bad things, alcohol, and insulin, part of the inflammatory pathway. So be careful with your alcohol consumption and keep your inflammation down so you don't get insulin resistance. Coffee, should you drink coffee? Should you not drink coffee? Well, yeah, it's got caffeine, so yeah, go ahead. But it's got a whole bunch of other things in it that act to improve your inflammation. And you know what? I just found this out. It's a potential antifibrotic. So probably through its anti-inflammatory properties, it decreases fibrosis, and that's one of the things we need for lipedema. How much water should you drink? I get this all the time. I drink a gallon, I drink 8 glasses, and I'm like, I don't know how much water you should drink, but maybe it's not water you should be drinking, but maybe it's electrolytes. So they showed that if you put electrolytes in water, it's a lot more hydrating than water itself. Orange juice, tea, and milk are also better hydrating than water. So maybe we should be getting our fluids from other things, including water, but also maybe our foods, right? And if you talk to a vegetarian that only eats fruits and vegetables, they don't drink a lot because they get a lot of fluid from their food. So I would just say, drink the water that you want to drink, but look at other things that may help you hydrate your tissue. The question is, how much sodium should you take in? And I think you should go talk to Shelley. We've talked about vibration therapy for years, like vibration helps your tissue, vibration helps your tissue. This is a study showing that if you added vibration therapy onto manual lymphatic drainage therapy, it improved the lipedema tissue. So we're right. So keep going. How many calories do you burn if you have lipedema? So this is a study that measured the actual, or the little a, resting metabolic rate, aRMR, and also compared it to predictive equations. So you go to your gym and they say, I predict this is what your resting metabolic rate is. And it turns out that women with lipedema in this study burned about 1,700 calories a day. But all the predictive equations did not predict the number of calories that you actually burn. So they predict that you need to eat less. So be careful about that when somebody calculates how many calories you should be eating. Don't undereat because your body will hold on to fat. And this is a study, so we always said, lipedema, resistant to diet and exercise, but we didn't really have any good data. So this is a study looking at a low-carb diet, and they actually calculated the amount of calories that they should eat in this eucaloric diet, which looks at how much you take in and how much you put out. So they may have underestimated the number of calories that they should be eating in the study. That's just something to keep in mind. But they all lost weight, which was fabulous. Their pain went down at 7 weeks into the study, which was fabulous. But by week 13, their pain had come back. So something's going on. Something's going on outside of a low-carb diet. Something is not addressing the pain component, and that's what we need to figure out. This is another study on that just came out by Manuel Corneli from Cologne, Germany. And look at this woman. Look at how much weight she lost after bariatric surgery. We always say lipedema is resistant to bariatric surgery. So could this woman only have a little bit of lipedema, but a lot of obesity? And could another woman have a lot of lipedema and a little obesity? How do we figure that out? And what they found in these women were after they had bariatric surgery, they still had pain. Their pain did not change. So again, there's something different about the lipedema tissue that causes pain. And finally, they looked at the Mediterranean diet. This is from 2021. And they compared women or controls to women who had lipedema. And they called them lippy. I didn't call them that. They called them lippy. That was not me. And the beautiful thing is on the Mediterranean diet, they all lost weight. So you can lose weight on the Mediterranean diet. But check this out. The controls lost percentage of fat pretty much so everywhere in the body. They lost fat from everywhere. Look at the women with lipedema. They didn't lose much fat at all. So again, there's something different about the lipedema tissue, and you can take the study and show your doctor, see, it's different. It's not being lost by diet, at least not the Mediterranean diet. Maybe a low-carb diet's better. We just still don't know. 9 minutes, okay. And I would say to the professionals, be careful when you talk about dieting with women who have lipedema. It's not about restricting. It's about eating healthy. And this is a study that came out by Tom Wright showing that women with lipedema are at risk for eating disorders. And we've all known that. You know, as you grow up, you tried everything you possibly could to lose the weight that you weren't able to lose. And also, another study has shown that women who have hypermobile joints also are at risk for eating disorders. So you get a double whammy if you have hypermobile joints and lipedema. So professionals, we need to be very aware. Leptin is a big interest of mine from way back when, because you can develop leptin resistance where your body doesn't know how much fat you have because your brain isn't recording the amount of leptin in your body. And that has to do with inflammation. So Sarah Al-Gadban and her colleagues showed that leptin gene expression was higher in lipedema adipocytes. So higher is good. More leptin, decreased fibrosis. So how can you have increased leptin and you still have high fibrosis? Something is not right there. So if you're cranking out leptin because you're trying to show the body that you're there as a fat cell, but your body's not recognizing it, then maybe you have leptin resistance. So there's a medication called telmisartan. It's a blood pressure medication, and it was shown to reduce serum leptin. And maybe what it did was made the body more sensitive to leptin, so the brain recorded how much leptin there was in the body. And it actually improved markers for liver and kidney fibrosis. So maybe what we're doing here is finding medications that if you do have high blood pressure, maybe there would be a better medication for you to go on that would help your lipedema at the same time. So is telmisartan a possible treatment for adipose tissue fibrosis in general and also in lipedema? And also, what just came out is this new adipokine called orosomucoid. Let's say it right now, orosomucoid. And it alleviates adipose tissue fibrosis, like gone. So if they knock it out, the fat became fibrotic. If they overexpress it, the fibrosis went away. So maybe this is a pathway that we should be looking at for lipedema. And this actually activates the AMP kinase pathway. So you don't have to really know about the AMP kinase pathway in essence, which is shown there. But what's interesting is that there are a whole bunch of phytochemicals, so plant-based chemicals, that actually activate that pathway. So even if we don't have that adipokine yet, it's okay. We've got all these other phytochemicals like berberine, like curcumin, right? Or turmeric, from turmeric, and a whole list of others. So I think in the future we should be looking more towards a mixture, maybe a cocktail of phytochemicals to help decrease inflammation in the tissue, make it less heavy so it's not pushing down, improve flow through the tissue. And I know that no one here has vascular Ehlers-Danlos syndrome, but I just wanted to point out that there is now an orphan drug for vascular Ehlers-Danlos syndrome. And that means that the potential for drugs for other hypermobile conditions may be coming up in the future. So I just felt like that was such good news. So surgical treatments of lipedema. So this is a paper by Krupa, and I thought the outcomes were great. I thought that there was a great reduction in the amount of lipedema tissue on the body. But the more important thing that came out of the study is that the women who were treated early had a better improvement in their signs and symptoms than women who were treated late. And even though that makes sense, right, we needed to prove that. So I think that's been proven. So we're back to we should be identifying lipedema early and we should be treating early and not waiting until you have a massive cuff sign and the insurance company goes, okay, your cuff is big enough, now you can be treated. And they also came up with the pinch test. After you do the liposuction, you should be able to pinch your fingers closer together than keeping them apart. I thought it was cute. And we published a paper, it was just a questionnaire study where we asked ladies with lipedema, like, did you have surgery and what happened to you? And they found that their walking improved, their quality of life improved, they lost weight, they even reversed their stage after liposuction. Pain reduction overall decreased, but I wanted to point out there's some women who had increased pain after surgery. And if you have increased pain after surgery, that's it's 100% for you. So it's not perfect, right? And there's always a risk. When you have surgery, you take a risk. But if you look on the right side, there's all the kind of bad outcomes after the surgery. And for the most part, women did well. Anemia was present, wrinkly skin, sagging skin, those were common things. Uncommon things included DVT, cellulitis, and skin folds. And I know I was talking about surgery, but there's a paper that came out showing that maybe there are non-surgical means for reducing lipedema tissue. And these including an anti-inflammatory eating plan, getting in the pool, manual lymphatic drainage, if there's edema in lipedema tissue, and antioxidant herbal medications listed there, right? And that's kind of similar to those AMP kinase phytochemicals, right? So plant-based chemicals help reduce lipedema tissue. So in conclusion, I think we need to all be aware of the politics in the field of lipedema, and we need to focus on the science and not just making ourselves feel important. If someone wants to feel important, they can put on a show, right? But that's not reality. What reality is what we can prove is going on. So let's continue to see both sides of the coin until we figure it out. And reduction of obesity is important in lipedema, but the lipedema tissue that remains is painful and different from non-lipedema tissue. And women's tissue is different from men's, and that's something we need to be looking at. And there are conditions that are associated with lipedema that we can learn from to improve care of people living with lipedema, and that includes mast cell activation disease, I think. So look for fibromyalgia, hypermobile joints, autonomic nervous system dysfunction, which can happen with mast cell. And it's likely that more medical treatments for lipedema will be available in the near future. So thank you very much.
We have time for a question. How do you know if you have fibromyalgia in addition to or instead of lipedema?
That's a great question. Sometimes it's really hard to tell, but again, the widespread pain versus the isolated pain in the tissue. And also, if you want to go get tested, that would be another piece of information that you could add into the mix.
Given the political, social, medical culture surrounding overweight and obesity, how do you see lipedema and other fat disorders being regarded or legitimized as worthy of study and treatment?
I think the tables really have turned. I think more and more people are interested in fat. They're not looking at fat just as a place where you store triglycerides. And I think people are coming to understand that there is fat you can't lose by diet and exercise, and that's just not in the lipedema field. That's in the obesity journals. Okay, there's multiple studies showing if you have fibrotic fat, it's less likely to be lost after bariatric surgery. So I think there's just a huge surge in the interest in fat tissue because it really makes, fat tissue makes our shape. It makes us who we are. It makes us attracted to other people. And why wouldn't we want to study something like that?
Absolutely. Thank you so much, Dr.
Thank you.
Just